right, let's settle down. Thank you. Thank you so much. Thank you so much. My name is Ruele Okeyo, and yes, this is a debate session. Are we excited for it? Yeah? Yeah? That's it? Thank you. All right, fantastic. So, just quick housekeeping rules. Please, let's have our phones on silent. This is the Game of Thrones, okay? Winner takes all, 7 kingdoms, okay? Right. So let's have our phones on silent, and we are going to have a wonderful, wonderful session. So I'm going to start by introducing my, how do I call them? Warriors. Thank you. Warriors. Our warriors ready? No pressure, guys. No pressure. But hey, the people are depending on you. The 7 kingdoms lie in your hands. All right. So who the queen in the north is Elzette Rousseau. The queen in the north. Rousseau. Woo woo. All right, so Elzette is a social, behavioral, and implementation scientist at Desmond Tutu Health Foundation. Yeah, fantastic. Right, the queen in the north. All right, we're going down to Winterfell, and the lady of Winterfell, Allison Agwu, the lady of Winterfell. Yeah. Dr. Allison is a professor of adult and pediatric infectious diseases at Johns Hopkins University School of Medicine in Baltimore. But today you're in Winterfell. Okay, today you are in Winterfell. And now on to the Baratheons, okay? The Baratheons, we have Oaphela Boago. Oaphela Boago, woo-hoo! Is a first-year student at the University of Botswana in Gaborone and is currently enrolled in a Bachelor of Arts in Social Sciences program. Right. And last but not least, we have the king of the king of the north. We have Nyiko Kubai. Nyiko Kubai, make it to the stage, okay? Fantastic. We all know Nyiko, right? Okay, fantastic. So, we're going to keep it short and sweet, all right? Jugulars are protected for now. Eh? Yes, we are saving the jugulars for now. So, the rules are really simple. We're going to have an introduction for the topic. So today's debate is the injectable treatment and prevention should be reserved for people 16 to 25 years, right? We got that, eh? Injectable treatment and prevention should be reserved for people 16 to 25 years. So, what do you think? Is it a yes? Is it a no? Right? You can keep your votes coming in. Join at menti.com and use the code 27803755 or scan the QR code that is on your screen. Menti is 27803755 or join the QR code on your screen. And first, are we ready? Okay, so everyone gets their own mic. Here is Nyiko, so that everyone gets their own swords. Those are swords, right? So we're going to have the proposition going first, right? Elzette, the floor is yours. Slay this, folks. Your slides, please. Any weapon of your choice.
Should we wait a little bit?
Should we wait? Okay. All right. We can wait. All right. People of Winterfell, cast your votes. We are waiting for you to cast your votes. Right. I see likes. You're all supporting Joffrey if you're not voting. Yeah. Or it's going to be the red wedding at this point. But hey, no spoilers, eh? No spoilers. Yes? No? Yes? No? What are our opinions on it? Should the injectable treatment and prevention be reserved for people aged 16 to 25-year-old? If it's yes, why do you think it's a yes? Please hold your answer. If it's a no, why is it a no? We're going to come back to you shortly. Yes, so, is it the Wi-Fi, guys? Yo, how, Habarone? Hey. Okay, in the meantime, then, we can proceed with the Queen in the North. Yes.
Hey, good afternoon, everyone. I'm Elzette Rousseau. I'm from the Desmond Tutu Foundation in South Africa. Very happy to be here today. So I'm for the proposition. Definitely, we should keep injectable treatment and prevention and reserve it for people 16 to 25 years old. Here are my disclosures. I recently had a conflict dynamics profile done by an organization, and it said that I score very high on winning at all costs and also retaliation, just leaving it out there. Now, let's get into this presentation. These are things that we all know, that we're going to focus on, what is the greatest health impact. That is our first argument for the proposition. We know, especially in the African continent, it has the highest HIV incidence, and we see there that even though incidence is going lower in other age groups, in the 10 to 19-year-olds, it is still increasing. This is still, in 2024, data showing us that this is a population that is still acquiring HIV. And it is really from the previous presentation as well, because they are facing this really perfect storm of a heightened HIV acquisition environment. We know that they are facing things like amplified STI epidemic, low viral suppression, low condom use, intimate partner violence, economic inequalities. It goes on and on and on. Because of all those things working together, it makes that every single sexual encounter is potentially a very risky one for them. We also know, like we just heard, about the neurobiological development of these young people. It is really hard for them, and they have delayed self-control in situations that's maybe emotionally salient, that we saw. They have high emotions. That is when they have to use their condoms, and also difficulty with continuously taking one pill every single day. We also know that adolescents have poor HIV treatment adherence, that you can see from this results. And so this results here show that only about 40 to 60% of participants younger than 25 have continuously high adherence. And between all the age groups, you will see that that's where they consistently have decreased adherence or continuous non-adherence. So when we look at that, that means that it will reflect that over a period of time, there's normally like long interruptions in the ARV use or discontinuation. Let's be realistic. I think today is going to come down to, are we for or against? But we need to be realistic. What is the real thing going on here? There's a limitation of resources. Funding has been cut. Products are not cheap, and it's not free. And also, to be realistic, if we prevent HIV in young people, it will avert decades of treatment costs. So this is the population to look at. So when it comes at cost effectiveness, while the question, I'm not just saying that we should choose this population because I feel that is the vibes. I have here a modeling study of very smart people that came out earlier this year, saying that when we look at, and I know this is even for me very hard to understand the cost effectiveness ratio, so to break it down for you, when it shows a lower cost, that means that's the cost to get a health benefit. Okay, so if we look at the lower box where it says that first group, $280, if we give LEN and CAB for treatment, unrestricted, all ages, all genders, all sex, then it's going to pay $280 for the health benefit. If you take it right to the end, if we reserve it for 15 to 24-year-olds, $18 only for the health benefit. Also, we must look at what is the window of opportunity and really, I think, grab it in this instance. You'll probably hear in the next presentation things about equality. But let's get down to it. It's not about equality, it's about equity when you have limited resources. And equity is you really get products to the people who need it. And this is not new. We've done it with the HPV vaccine. With the HPV vaccine, we've reserved it for certain populations where we know there will be impact. This data that was released 3 years ago, where they tracked women for 10 years after they had any type of intervention for HPV, whether it was just screening or whether they got the injections, show you there that there's a significant decrease and lower rates in cervical cancer in the cohorts that received the injections while they were at school at a young age. So this is not new when we say reserve it for a specific population. But also what an opportunity that would be. Imagine if we can in every school take injectable PrEP, injectable treatment and give it to everyone. You will get rid of stigma because HPV vaccine doesn't have a stigma because everyone gets it. It's just part of life. If you're at school, if you're that age, you just get it. It becomes routine healthcare. Now, I just want to also just speak about my fabulous opponent. She's a professor, guys. I'm just a doctor. She's a professor. I did mention I'm from South Africa. She's from America. You all know America? The US. So when we speak about, she's going to speak about inclusion for all. I just want to break it down for you. What will it mean when she says inclusion for all? We saw about 2-3 weeks ago, there was the biggest oxymoron that I've seen in my life. America first, global health. Global health, America first. I don't know if that computes for anyone in this room, but that is what will happen. It will be America first. And also, I'm not just making this up. This has happened when it came to COVID-19. If you look at the statistics of who received the vaccines, 4 billion people in high-income countries, 270 million in the low-income country. It's the same thing that will happen. But let's give them the benefit of the doubt. Let's say they say everyone will get it. When it comes down to policy, it is not everyone who gets a product. This systematic review will show you that even in countries, this is 19 African countries, where they in their policies say that they're going to give oral PrEP in this instance for everyone. If you really drill down to who gets it and go deeper and deeper, it starts being a lot of no's for LGBTQI people, a lot of no's for men who have very young partners, people in the rural areas, etc. So in summary, I have 20 seconds left. Didn't we all say I want to be the part of the generation that ends HIV? That generation is 16 to 25 years old. So if you say you want to be part of that generation, and if we can give all of them in school or where we can find 16 to 25 years old, can we not end HIV? We will normalize it for young people if we take it into their schools, if it's for everyone that's going to get it. And also, it doesn't mean that's where we end. If with HPV, with COVID, we also saw that we target someone first, and then where there's more money, if America says they don't want to be first again, we can add someone else. We can give it to other populations. Thank you so much.
Oh, goodness. The jugular was touched. Came for the jugular. The jugular was touched.
I thought we were going to be nice.
Gloves are off.
Go back. So injectable treatment and prevention should be reserved for people 16 to 25. Please be on the right side of history here against this proposition. So let's talk. We're at an adolescent conference, and we oftentimes focus on the adolescents who are acquiring HIV, and there are a lot. This is UNAIDS graphic, which lumps adolescents in, those 16 to 24, into the 15 and above. Right? And we all know, you've seen these slides, where those young people are, where those people living with HIV are. We know where we are. But let's talk about it. Who else is here? So that's 40% on average worldwide are in the 16 to 25 years range. So who else makes up the people who are acquiring HIV? It's babies acquiring HIV in utero and breastfeeding, pregnant women under 16 and over 25. It is the adults who have actually the 26 to 44 are right there, close battling with the 15 to 19. And then all the key populations under 16 and over 25. So for the proposition, our esteemed colleague here would want us to leave all of them behind. We know there are inequities, and we talk about those. Yes, The US has much more PrEP happening than other parts of the world. Thank you, we acknowledge. Though we're dismantling those systems as we currently speak. So we know there are inequities. But we've seen the successes and what's coming and what could come. So we've seen 083, 084 with cabotegravir or Aptitude, and we've seen the campaigns to roll that out. We now have lenacapavir, and we've seen the exciting news about lenacapavir. 0 infections, and those studies happened here in South Africa and Uganda, and included pregnant women, meaning those babies did not acquire HIV, 0% incidence. And then we went to those other populations, right? The other ones that were not including, the gender varying, the men, et cetera, and super, super, super effective. It's important to say PrEP works, all PrEP works, but we know that injectable PrEP works better. And there's more studies coming. WHO, the CDC, is now pushing lenacapavir forth. So for LAI for prevention, there's some key concepts. It's about expanded choice. It's creative delivery models. I'm not saying we're just not going to do it because it's hard. Let's figure out how to do it. Innovation is needed. And there are key populations of all ages that desperately need it. And yes, I'm going to talk about equity and access, because I should. So lock in. Let's leave no one behind and figure out how to do it. So let's get to care, management, and therapy. Who's over 25 in the room? Sorry, you can't have it. All right, so this is life on the continuum of care. We know that it's a long process, and now we're talking about comorbidities and addressing that. But injectables is part of that. We can get to U equals U or undetectable equals untransmittable. And these are the many reasons in all the studies, many of them on the posters in the back, that talk about why adolescents have issues with adherence. I forgot, I traveled, I ran out of pills, depression, stigma. You know who else has those issues? Everybody else. Jugular. So we know there are gaps in who needs to be on treatment, who's getting, and we know there are gaps for adolescents, major gaps. But there are also gaps for other populations in all the parts of the world. And even in the US, with all of our happiness, our viral suppression is 60%. Long-actings have the possibility to address this. This is a latte study. I won't bore you. Happiness, okay? These are the HIV outcomes in children, the ones that my esteemed colleague wants us to forget that they need access to. And pay attention to the very, very special parts of who's actually suppressed, right? In the red are those who are not suppressed, and in the yellow are those who are on ART and virally suppressed. So you see there's a lot of blue, they don't know their status, a lot of red, they're not suppressed. There's an app for that. So MOCA looked at injectables for those 12 to 17. They did well. Crayon is looking for those all the way down to age 2 and is fully enrolled, and we'll get that data. So that access could be there if we now have the data, but our colleague will want our young people to not be able to get it. So they won't even get to adolescence. Jugular. And then there's breastfeeding. Here's what you see is a number of children who are being born with HIV and acquiring HIV during breastfeeding, and we see that number going down. But we also see that the proportion of pregnant women who are actually getting antiretrovirals is not perfect, and some places worse than others. If they're over 25, those pregnant women will not get injectables. When we look at who did not have access to ART during pregnancy, 58% of those pregnant women were in Western and Central Africa, 23% were in Eastern and Southern Africa, 10% were in Asia. There are studies that are happening or trying to happen to look at injectables during pregnancy to prevent transmission. So don't shut the door. There are treatment needs. The key concept are expanded choice. It's durable viral suppression. People are tired of taking pills. You can take a pill, but you're tired of taking pills. And that happens if you're under 16 and if you're over 25. There's ART resistance, where we need to think about how injectables may be part of that. There's decreasing comorbidities, if we can get people to suppress durably. There's optimizing survival, and there's treatment as prevention. All these are key concepts for key populations of all ages. And yes, there are key challenges, and equity and access are critically important, and we have to continue to fight and innovate to address. So my friends, 82% of you who already agree, please vote against the proposition. Be on the right side.
Amazing. It's getting tough, ne? Oaphela. All right. Go for the jugular. No jugular is left unspared.
Everybody speaks about being on the right side of history until it's actually time to do something. Ladies and gentlemen, it's time to side with the people that actually care about being on the right side of history. That is the people that care about the people who are vulnerable, who are put in compromised situations. My name is Garetshoge, and I am the community speaker for the proposition side. We believe that PrEP and ARVs should be limited to people of ages 16 to 25 because, one, it protects the young children who are in compromised or vulnerable situations. Multiple statistics show and tell us that there are many children under these age ranges and within these age ranges that are in vulnerable situations, be it sexually, be it molestation, be it rape, etc. Limiting ARVs to this population protects them from contracting the virus due to means that they weren't intentionally in. For example, a person might be put in a situation where they are in an abusive household and they aren't able to get out. Limiting ARVs to these people allows them to be able to be safe without having to put themselves at compromise. For example, they wouldn't have to deal with the multiple intrusive questions that come up in the clinics, etc. Moving on to the next point. Young people are much better at coping or dealing with the side. My slides decide to work, but my slides are moving against me, but we can move anyway. Second of all, young people are much better equipped to handle the side effects that come with ARVs. The opposition failed to mention that ARVs are much harder to handle on older people due to health complications that come with age, due to lifestyle changes. It is much harder to implement lifestyle changes when you're moving towards your 30s, towards your 40s, towards your 50s. Let's be honest, your schedule is busy, you got a lot of medications coming on, and imagine taking ARVs that can reduce your lifespan at such an age. So it's much more reasonable to limit these to younger people who are able to implement these lifestyle changes, and are able, I mean, it's just honest fact, but they are able to reduce or limit the severity and the frequency of these ARVs. Moving on to my last point, but definitely not least, we all speak about youth empowerment. The reason why we're here is because we believe in sexual empowerment of our young people. Believing or agreeing with this motion means that you are agreeing with empowering the youth. Young people want to be able to express themselves sexually. Remember that over the past day, even yesterday night, one of the issues that were being raised, even the previous session, was that young people aren't able to express themselves sexually. That they are afraid that they're put in boxes and cages when it comes to issues of sexuality. Limiting PrEP and ARVs to this age group allows them to experiment and push boundaries in ways that do not put their health at risk, and they do not put their partners at risk. To close my argument, ladies and gentlemen, and everyone who's in between, I'd like to say this. Everybody wants to be on the right side of history until it's time to take action. Take action now. Vote the proposition. Thank you.
Hey, hi. Yo. Okay, all right.
I can't believe that you guys are clapping hands for this. I know you really want to support them, but you don't support this proposition, right? Yeah. So I believe as a community person that long-acting HIV treatment and prevention strategies are beneficial for all populations, not just young people from 16 years to 25 years, so I'm against the proposition. because they are effective for many groups facing challenges with daily oral medication. And these formulations offer improved comfort, increased discretion. We know that most of us are struggling with this, and the treatment is making so much noise, especially for us young men. And then, and the way to overcome this barrier again is another way is that stigma, this one big elephant in the room, is mostly centered around the conversation of poor adherence, pill burden. We know, guys, we can't keep on reminding you about these things. And then I do believe that if we could allow all populations to access these new long-acting formulations, would be introducing a game-changing approach, because it doesn't only have the opportunity to, it's not only appropriate for the loudest group, but for all the populations, because we live in a community, not in the HIV and adolescence workshop, right? So when you go back to the community and you have access to long-acting treatment, and your brother who's 26 years old doesn't have access to long-acting treatment, that would create some form of division in our families, guys. So let's try to think of these approaches as approaches that would serve a community, not the loudest populations in our communities. And we as young people, us being here, we are not just representing our values, but even the aging population values. We know that young people, especially children, are struggling a lot with adherence. We know that the drugs that they have, they are not friendly. They have severe bacterial infections. There are so many complications centered around young people, so around children. So we definitely need long-acting solutions for children. Can you please clap hands as I continue? Just for moral support. So guys, I think another important aspect that we have to think of, if I am applicable or if I'm eligible to access long-acting treatment at the age of 15 years old, well, I'm switching from, at the age of 14 years, I switched to long-acting treatment at the age of 15 years. And then when I reached 25 years old, I switched back to oral treatment. Why? Why introduce me to long-acting treatment then? Because you're confusing my train of care and the whole HIV management. So I would say, guys, just go against the proposition. I think even this conversation is below my standard, because if you are saying cost effectiveness is one thing that would be an argument against access for everyone to have long-acting treatment. Come on, guys. Come on. Because we cannot think of, we cannot promote cost effectiveness at the expense of leaving important populations behind. Like we say, we leave no one behind, guys. Keep on clapping hands for me so that I can keep on spitting fire. So guys, trust me, we live in a community of different diverse populations, not just young people. Us being here, we're representing our specific values, but we go back to the community. We have our parents, we have children that grow under us. Guys, you know the right decision. Thank you.
Ish, it's getting hard, ne? Yo, okay. So, no jugular. I thought you were playing nice. Ish, following rules is really hard, ne? Okay, now I'm throwing it back to you. I'm bringing the battlefield to you folks, right? I already see a hand over there. Ish, guys. Okay, let me finish my sentence then. The injectable treatment and prevention should be reserved for people 16 to 25. What are your thoughts? There is a hand over here. That was the first hand to go up. We have one over here and one over there before we come back. Okay.
Okay, firstly, I'm against.
You're against?
To this group, and I'll go even further than that and recommend that we give it to pregnant women. And there's a few reasons around that.
Yeah.
The first one is missed doses have greater consequence in pregnancy. Okay, viremia when you're pregnant or breastfeeding can lead to infection of the baby.
Yeah.
The second thing is, if you get infected at 15 years, 16 years, as compared to being infected at birth, I'm already saving the government 15 years worth of treatment. You understand that they would have to give this baby.
Yeah.
So I'm saving money at the same time. The other issue is look, the most vulnerable group is the kids. If you're infected at birth, the chances that you are going to fall ill before the first year is probably 50% of them will definitely be ill by the first year.
Yeah.
16-year-olds have established immune systems, okay? If they get it, they still have time before they start to cost us money, okay? So I vote for against this.
You're
and
good.
prefer to give it to pregnant women.
Okay, all right. Thank you. Thank you so much. Number one. Are you against or are you proposing?
I am not against, I am for. Like, I agree with the motion that says 16 to 25 should be prioritized on injectable treatment and prevention. I do solely agree with my head on the ground that this should be prioritized. Why? Because across Africa, I'm going to talk as an African young person, living and have seen everything that went on. So I am a living testimony of this motion. Anyway, I, Olorato Khululo, solely agree that the injectable treatment and prevention should be reserved for the 16 to 25 years. Why? Because this will save the government the stress, because we are leading when it comes to STI infections and new infections, and HIV, we are still leading. And then the treatment for this STI is very, very costly for the economy. Economy will like guys, and we should do the right thing. What I'm saying is the economy has fallen with its stomach, so we should make the right decision and help save our country. Right now, when the stop order was being said, like the funds were cut, we were unable to stand and help our community and help our country. Why? Because most of the resources are channeled to the HIV treatment and STI treatment, not being used for other things, important things. Rona, we rely on diamonds. And those diamonds, the little 45% we get from the DBS, we use it for HIV treatment. What about other things? We talk of creating employment for youth, but we cannot create it. Why? Because treatment is taking resources, funds. So let's just use our heads to think.
Okay, all right. Okay.
But I think when you started your argument, you said prioritize. Then you led to saying reserve. Then I dozed off. Because
Nyiko,
these are, sorry for taking the conversation. Maybe if you understood the proposition much more better, maybe you might be against. Sorry for saying that, but I had to clarify that. Thank you.
Yo, number three.
Yeah. Hi,
Are you
Nyiko.
opposing or are you proposing?
I am against it.
Okay, sharp.
Yes, my name is Doreen Moracha. I have been living with HIV for 33 years since I was born. I have been on treatment for 20 years. I need the injectable treatment. Why are you shutting me out? For what reason? And when we innovate new HIV prevention and treatment, we are expanding choice and access for all, not exclusion. If we reserve injectables for 16 to 25-year-olds, we fail the very principle of equity in healthcare. The fight against HIV needs inclusivity, not age barriers. Thank you.
Ish. Okay, it's getting hot. Okay, number two. Okay. Are you opposing or proposing?
So I'm in agreement.
You're in agreement.
Should be reserved for the 16 to 25 years. And I am conflicted as I say this because I hear the demand all over. But the thing that swayed me is that we cannot get away from the fact that we have scarce resources. So I would reserve it for that population because the modeling study says $18 versus the other amount. And as she said, you know, we've got lots of other kind of interventions that were rolled out in a phased approach.
Yeah.
It will get to the others,
Yeah.
but it must start here whilst we don't have the resources. Thank you.
Okay. All right. All right. Number one. Number one.
Thank you so much. My name is Jean. I'm from Livingstone, Zambia. I'm against the motion, which is stating that the injectable should be reserved for the 16 to 25. Why do I say so? First of all, I think we are moving to, in public health, we are moving towards promoting choice. And from my experience as a provider for PrEP as well as ART services, I have noticed that when a client comes for PrEP, our role as healthcare workers is to give them the available options. And then each method has its own advantages and disadvantages. Yes, you may say the TDF-based regimen might give you a kidney problem in future, but also cabotegravir, for example, it also has its own side effects. Yeah, so for me, I believe in giving the client the available options, let them choose for themselves, and it has actually proven to improve retention. Thank you so much, and over.
Thank you. All right, moving on swiftly. Number 3 and then number 2.
I believe it's good evening. So our motion is to work on eliminating HIV new cases. So how would you say you are eliminating HIV new cases while you are leaving the most vulnerable generation, which is 0 to 15 years behind? How do you do that?
Okay.
Wait. Okay. And one more thing is, we are also working, mind you, we live in communities. How would you reach out to the same youth without involving the elders, the people that are there, eligible for you to access those 16 to 25? You talk about vulnerability. Vulnerability starts from the age that you are born. You won't know the day or year whereby you encounter maybe a situation whereby you are forced to end up having something that will lead you to contacting the virus. So talk about equality. You can't be saying equality when you are excluding that community that.
Okay, thank you. Thank you so much. Number 2.
Before they can proceed, just a quick side note. Bear in mind that this age group is also one of the leading populations in Africa. Africa is considered a young population, so reserving this is basically limiting it to the greater population or to the people with the greater needs in the continent. You mean to tell me you want to ostracize a large percentage of the community because policymakers, etc., do not want to reduce their costs because, oh, we want to cover every single person, but then the resources aren't even getting to everybody? I mean, cut to the chase.
Oaphela,
there are gaps.
Calm down. Hey, calm down.
I think she's scared. Calm down.
Hey, calm down. I'm scared. Calm down. Okay. Number 2.
Good evening.
Good evening.
I'm Purity Mfarashi Nyatondo, and I work with Joandiri as a peer counselor. So I'm at the opposition side. Why? Because HIV doesn't discriminate. So neither should our interventions be. And
Hey. Okay.
And for example, a 35-year-old young sex worker, a 35-year-old sex worker may be at high risk compared to a 19-year-old young person. And local epidemiology matters. In communities with high HIV prevalence, everyone is at risk regardless of age. Everyone is at risk regardless of age, and also everyone should have access to these most effective tools. So I'm at the opposition because we are saying that we want to leave no place and no one behind, and yet we want to discriminate those from 0 to 15, and also those 16 and above. Let's not do that. Thank you.
All right. Number one. Guest number one, thank you.
Good evening, good afternoon, everyone. My name is Bridget Mwape. I'm a midwife, a Global Alliance champion to end AIDS in children. And when we leave our children, it breaks my heart. Because for us to have those adolescents, we need to target the pregnant women during delivery, during breastfeeding, so that we can have the health babies, and then we can protect them at that age group we're looking at. So I'm against the motion.
You're against the motion. Okay, thank you. And while we're at it, also, we can have the Menti up so that you can keep your votes coming in, okay? Thank you. Number 2, and then number 1. And you can tell us if you're against or if you are proposing.
Good evening, everybody. I am Tolofelo from Botswana. I'd like to start with saying I am against this motion. And I'm going to shift the room for a bit. Earlier on, we were sympathizing with our lovely adolescents and how they need help. And our lovely speaker did mention that they have a thing of expressing themselves sexually. Are we together? Now, I'm saying this could lead to protecting them against HIV, but what about other STIs? And with antimicrobial resistance on the rise, don't you think we could be shortening the time to making these superbugs that will be resistant to all treatment available? That's a point to think about. Thank you.
You came with receipts. Ish. Number 1 and then number 3.
Yes, I'm going to be very short. I'm against, and I'll just start by posing this question, especially to everyone in the room, but to Botswana. Under the leadership of His Excellency DGB, who is speaking to the cornerstone of protecting human rights and having human rights-based approaches to programming, equality, non-discrimination, access to healthcare facilities for all, without excluding, inclusivity. I rest my case.
Hitting the nail on the head, ne? Do you have a rebuttal? Okay, number 3. Number 3.
So, good afternoon, everyone. Yes, so I'll start with this melody. Which
are you against or are you proposing?
I'll come to that after the melody. So, I'm sure this is a popular song that everyone knows. It goes like this: one love, one heart. Let's get together and feel all right. So definitely I'm against the motion because everyone deserves to live a healthy life. Everyone deserves the right to access. We all need the injectable treatment and prevention, and it shouldn't just be for the 16 to 25 years old. I rest my case.
All right, thank you. One love. Number 2.
Okay, I am against the motion. The motion is assuming that young people only get infected by fellow young people. And I didn't check the data today, but what I believe is that a lot of young people are being infected by older people. And we really need to have these older people. I mean, we need to prevent the infection in the older people. We don't want to overemphasize just the importance of preventing newborn babies from getting the disease. I think you already talked about it.
Yeah.
Thank you.
All right, thank you. Number 3.
Hi, I'm Alex. I'm going to be a bit of a devil's advocate here and actually attack the statement itself, because I think there's a difference in population between treatment and prevention. And I think fair enough if we're saying that the 15 to 25-year-olds are highest risk of acquiring HIV. That's different from the population who need long-acting ARVs available for their treatment. So that's my contribution to the debate.
All right, thank you, thank you. Okay, so any last call? Last one, I see two. Okay, last two. One should be against and one should propose. That's the only condition. You have to be against or you're proposing. If not, you're against. Are you proposing? No, one has to be proposing. I'm the one with the mic. I am the one with the mic. I am the one with the mic. As we're finalizing, okay, let's have number one.
I'm against the motion of giving only to 16 to 25. Honestly speaking, when we are looking back the years, those who are above 25 by now, they have suffered a lot through different medications that they had to go through. Up until today, when they were taking now 1 tablet per day, with the hope that things will keep on improving. So as the things improve to the injectables, let them be given a priority because of the sacrifices they have done up to this time. So it will be a reward on their side for doing the good work. Thank you.
My people, man. Yo. Okay, lastly, we can have number two.
All right, thank you. So, we don't grow younger, we grow older. So the question is, what happens after the 25-year age pool? What's going to happen? Because those who are 4 didn't address that. So what happens after I turn 26? What's going to happen? Am I going back to the old system while I was introduced to a new and better treatment and prevention solutions? So.
Guys, you guys are holding my collars like this. Just because I'm with my head on the ground, I say I agree with the motion. I don't have a degree in law to stand with the people. But justice for the little one here, I still agree with the motion, and I say the injectable should be reserved for the 16-year-olds and the 25. I'm not a person who has fear. I don't have fear, especially when it comes to things like this, you guys. And I don't back down easily until you put a bullet on my forehead.
Okay, all right. Thank you so much. Thank you so much. So, hey, I told you the battle for the 7 kingdoms is not easy. It is not easy. But anyways, now we are going to have a battle, right? So you all went for the jugular. I don't know what you're going to do now, right? I don't know what you are going to do. Right, now it's finishing it off. Okay, so we're going to have a rebuttal session so we can get to hear which one goes to take the 7 kingdoms and sits on the Iron Throne. In the meantime, please keep your votes coming in on the Mentee, and then we are going to have a poll at the end of the session. So, proposers. Any. This is your case. Yeah.
Right. Thank you, everyone, for listening to that. Just a disclaimer, you who were against the proposition, you should not believe everything you read on ChatGPT. ChatGPT is not yet an adolescent or has been facing, potential infections. I could hear it. I could hear the hashtag stuffies. Also, we just need to get down to what the real stats is. We heard a lot of fake news as well when we were looking at the other presentation. When she was showing the numbers of infection, it was always saying from 15 to whatever age. So she was including in her stats the population that we are speaking about. So I just wanted to point that out. Also, what is this misperception that 16 to 25-year-olds are not having babies? I mean, they get pregnant, and we should stop thinking that they are not the pregnant mothers. They are this huge chunk of pregnant mothers. We are not excluding them. So please let's not go there. The whole thing about the age disparate relationship, definitely young people are getting infected by older people, but if they're on PrEP, they cannot get infected. If they're on treatment, have you heard of treatment as prevention? So don't worry about that old man. We're actually keeping your husband safe by giving these young women their treatment and their prevention while they are still between 16 to 25 years old. Lastly, the people that is for the proposition, I just want you to put up your hands and tell me who of you are giving $40 to $50 for one person to get their injection? No one? So who is going to pay for it? We can keep on saying they should have it and they should have it, but it's cost money. Who's going to get it? And if we maybe hear there's like 3 million doses, etc. If you really hear there's 3 million doses, who are you going to give it to? To everyone? To that 60-year-old man? Or are you going to reserve it for the 16 to 25-year-olds that need it? Also, you're speaking about Game of Thrones, which is a virtual reality. So let's get back to reality. It costs money. We are in Wakanda, a reality, not in Game of Thrones. Thank you.
I was just chilling. I was just chilling. I'm innocent.
Oh, yes.
Okay.
Raise your hand if you're above 25.
I'm scared.
Higher. Okay. Thank you. So my esteemed colleague, you may recognize her here, has spent a lot of time and gotten a lot of funding to look at novel ways of delivery for PrEP, for lots of population. She's looked at what's the challenges with it. She's looked at cost effectiveness. And in all of those studies, look at the age group that she looks at, 15 to 29. And let's hear her words. The long-term strategy is to give people choice, especially for young people, but not only young people. Simplicity and discreetness, cognitive burden, just go to the clinic and get an injection, and no one is going to find out. Thank you for those esteemed words. But let's talk about in their own words. What you look here is the sharpest declines in new HIV infections. The biggest declines are among children. Adolescents have declines, but you talked about not teasing out the age. 15 to 24, 15 to 49, what you're seeing is there's declines, but there's some who have not experienced the declines that even adolescents 15 to 24 have. But you don't want them to get any of this prevention, do you? Let's hear the adolescents' words. This is the Lusaka Declaration from this conference, from our adolescents. It was their call to action. They said the time is now. Accelerating access of effective long-actings, drugs to all for treatment and prevention. Look at that. We, the young people, think HIV treatment and prevention to all globally must happen. As innovations become available, inequities stall progress. Thank you for your words. So here's where we are. We have to realize the pledge to leave no one behind. If you want to go fast, you go alone. If you want to go far, go together. Be on the right side of history.
No. Yo, guys, ish. Hi. Hi. I. That was nasty. That was nasty. You went there. You really went there. Ish. Anyways, okay. So, here's the poll again. Injectable treatment and prevention should be reserved for people 16 to 25. Have your minds been changed for those who are opposing? And have your minds been changed for those who are proposing? There is the mentee. And here is where, this is make or break. This is make or break, right? Your vote counts. Yes, we can. Right? So let the votes keep coming in. All right. I'm not seeing any changes in the graph, so let's give it time, eh? This was nasty. This was nasty. I have no comments. I'm Switzerland at this point.
No, she was just accepting defeat.
Huh? No accepting defeat. No accepting defeat. Okay, the people will decide the fate of the 7 kingdoms. Yeah, I was just chilling. Okay, I'm harmless. Okay. Yeah. So, have your minds been changed? Has anyone's mind been changed by the rebuttal? No. Okay. I see a hand back there. So, okay, sir. Yeah. So, are the votes coming? Are they right? Thank you. Okay. Just keep voting. Okay. Okay. Should be reserved for people 16 to 25. No has 82. Yes has 18. Proposers. Doreen, your vote is your secret. Your vote is your secret. Okay. Yeah, so let's keep coming in. All right, so the final voting. Now there's a rule. Here's where I come in. Okay, and y'all don't better come for me. I'm an adult and I know how to fight. Okay, the winning team is the one that has convinced most people to change their vote, right? So I'm the one with the mic, so I make the rules. As many as they say, injectable treatment and prevention should be reserved for 16 to 25 years. If we're up for it, say aye. How? You? How? You as well? Ish. And those who are against injectable treatment and prevention to be reserved for people 16 to 25, say nay. The ayes have it. So I say. Okay. So yes, here are the votes. And yeah, injectable treatment and prevention should be reserved for people 16 to 29. So is it the against, right? Against. I have to give it to the against. Have to give it to the against. Sorry. 3% change. Keeps changing. 83. Oh, so. So who are the winners? Okay, can you come announce the winners? So 3% change. So is that a good thing or is that a bad thing? So it's still Dr. Allison and Nyiko who won. But y'all play dirty. Y'all play dirty. Yeah, thank you so much. Thank you so much. I really appreciate it. The 7 kingdoms go to you. May you bow down to your people. Thank you so much. Thank you so much, everyone, as well, for your participation for this session.